All right. Hello, everybody. I'm Dr. Eileen West. Thank you for tuning in today for our Ask the Experts series. I am very, very excited to be able to introduce a friend and colleague by the name of Dr. Asma Khapra. Today, she is a gastroenterologist. I'm going to give you a little bit of information about her, and then she's going to talk with us about women's gut health. So welcome, Dr. Khapra. We're so happy that you're here and grateful for you to take the time to do this.
Well, thank you for having me.
Dr. Khapra is a board-certified gastroenterologist. She's a clinical associate professor at University of Virginia Medical School. She's skilled in all aspects of gastroenterology and specializes in women's digestive health. Additionally, she has presented for national medical meetings, published several research articles, and authored an American Gastroenterology Association GastroSlides project for digestive health and disease in women. She has been voted by her peers and routinely recognized as a top doctor in the Mid-Atlantic region by Washingtonian Magazine and Northern Virginia Magazine. And she has been my go-to gastroenterology person since almost the day that I arrived in Virginia. So happy that you were here with us, and we're looking forward to hear what you have to say. And your presentation is going to be looking at a number of the most common questions that women frequently have about gastrodigestive health.
Well, thank you, Dr. West, for having me today. I'm actually really excited to do this because a lot of women come in with very similar questions, and so it was a great opportunity to kind of summarize these and talk about it in a forum that that people could listen to. So thank you again, and if we can get started, we'll get the slides up.
Let me go ahead and pull up the slides. There we go.
Fantastic. Well, as I mentioned, there's a number of commonly asked questions from my female patients, and you'll see them on the next slide that that's going to be in the talk. And I thought I'd quickly summarize them, and then we'll talk a little bit about the individual topics in detail. And feel free to, send questions if you have in between. So one of the first, and Eileen, you can move to the next slide. Fantastic. So the first question that people always ask is when their physician sends them for a colonoscopy, they say, well, why do I need a colonoscopy? And that's a loaded question, but we'll talk a lot about that moving forward. The other question is something about a topic called SIBO. And everybody reads about it and comes in and says, well, do I have this entity called SIBO? And SIBO is small intestinal bacterial overgrowth. And again, we'll get into that a little bit more in detail and answer some questions about it. Probiotics are the hottest thing these days, and everybody wants to know which is the best probiotic, and do I really need one? And so that'll be another topic we'll discuss. As women get older, they tend to suffer with chronic constipation. So we're going to talk a lot about tricks to manage constipation and new kind of methods and medications that are available these days. August is actually Gastroparesis Awareness Month. So we'll talk about what is gastroparesis because it's common in women. It's not very, very common, but it is predominantly seen in women. And then IBS is another super common condition in women. And everyone wants to know, how do I know if I have it and how is that diagnosed? And we can give you some tips about that as well. And then finally, hormones are a big key in the gut, and just a few kind of topics about hormones and how they affect the gut will be discussed in our last slide. So if we can start with the first topic about colonoscopies. So a lot of talk has been, or a lot of people have been talking in the news about colon cancer screening and colonoscopies over the last 6 months in particular, with some celebrity actually getting colon cancer and actually passing away from colon cancer. So I think this is a very timely topic. So the first question is, why should I do this, this procedure called a colonoscopy? Well, I always tell my patients, preventative medicine is the best, and that's what everyone is moving towards in this day and age. And most preventative procedures typically tell you, do you have the cancer or not? But this is the one type of preventative procedure that actually not only diagnoses a cancer, colon cancer in particular, but during the procedure, we actually remove polyps, which are precancerous lesions, and ultimately prevents people from getting colon cancer. So in one shot, not only are you able to diagnose a condition, but prevent something from happening in the future. So it's really a unique screening tool, and it's something that really everyone should be aware of. And the other reason that it's been in the news is because there have been changes in guidelines for when to get a colonoscopy. So in the past, people kind of knew the magic number of age of 50 as when the colonoscopy sort of schedule would start for prevention. But in the last couple of years, studies have shown that people are getting colon cancer at earlier ages. And just in March, the United States Preventative Task Force moved the screening age to start at age 45. So everyone who is of average risk in the population should be starting their colonoscopies and their colon cancer screening at the age of 45. So if your doctor hasn't mentioned that to you, you should definitely ask them about it, because it's just sort of coming up in the news and people are getting that information out to their patients gradually. Now, there are exceptions, and one of the big exceptions is for family history. So we know that there is a genetic link to colon cancer. And so if you do have a family history, particularly in a first-degree family member, that means in your brother, mother, sister, father, anybody in a first-degree relation, then the colon cancer screening should start at age 40 or 10 years before their cancer was diagnosed. And whichever one is earlier is that year that you start. So if your family member was diagnosed at 40, then you start your screening at age 30. So that's another thing that you should know. And then I haven't included this in here, but some people have certain genetic conditions which actually can promote earlier screening as well. But that's a specific, situation. Now, there is a lot of concern saying if I can't do a colonoscopy. So what does that mean? So colonoscopy is the gold standard. So if you want one test that's going to give you the best results, take care of everything at the same time, diagnosis, prevention, it's a colonoscopy. But what are the alternatives? So say you have difficulty, with other issues such as cardiac disease, and you can't get anesthesia for the procedure, or there's some other things that prevent you from getting a colonoscopy. What are the other alternatives? So you shouldn't not be screened. You should always look for the other alternative. One is a stool test called a FIT test. It's been around for a while. It's done annually, and it detects really blood or blood-tinged feces. And so that is something your primary care doctor can easily order. The newer stool test is called a Cologuard. It actually detects a number of things, and it's a combination of both blood and genetic material that's aberrant, so abnormal genetic DNA that you'll see in the stool. And it's a little bit more sensitive. The sensitivity and specificity is pretty good. And if that's normal, you would get, a colonoscopy, a Cologuard every 3 years as a monitoring tool. And very simple to do. It's just a stool collection. And then finally, the virtual colonoscopy has been around for a while. The problem with it is that it's not great for polyps under about a centimeter or so. So it doesn't detect small lesions. And the other thing is you do the same preparation for that virtual colonoscopy as you would do for a normal colonoscopy. So a lot of people don't want to undergo all of that to do this kind of screening. Now, if any of these are positive, what is the next step? Well, the next step is always to do an actual colonoscopy. So keep that in mind. And I'm just going to mention this, Dr. West, because I'm sure that this is an issue for patients in general, but there are insurance restrictions in terms of getting these tests and then further getting a colonoscopy in terms of payments and things. So patients should really talk to their insurance company so they're aware of what that is and how much they would owe if their test came back positive and they had to get a colonoscopy. Right now, colonoscopies are all covered by insurance as preventative measures. So if you came in you can get a colonoscopy very easily without, an out-of-pocket cost. So I didn't really have time to go into the details of kind of the preparation and everything, but I'll just say one thing. Preparations have gotten much better. Every time someone comes in for their colonoscopy, they say, oh, that wasn't so bad. So you sleep throughout it. People say they get a great nap. And so really it's the technology has become so much better than it used to be 10 years ago. So I really do encourage everyone at 45 to start talking to your doctor about getting your colonoscopy.
And tell us just a little bit about the prep, because everyone says it's the worst part. You know,
Yes.
it used to be that you had a very large jug of liquid that had to be polished off well before the procedure. And now I understand that volumes have gotten smaller, and you can even do it sort of in 2 installments.
Yes.
And you're even moving towards something you could do an hour before the procedure. Is that right?
Well, so there's a bunch of different kind of things that have been coming out. I'll tell you, the standard right now is so much better. So you will be on clear liquids the day before. Now, some people are allowing people to have maybe a light breakfast. And in certain situations, I will allow things like that the day before the procedure. But it's mainly clear liquids. And most people are okay with that. The volumes, you are absolutely correct, are much, much smaller these days. And the liquid has actually started to taste a little bit better. And the other thing is we started to split dose our prep. So instead of having a huge jug, I think the biggest one now is about 16 ounces in each sitting. So you would do it in the evening at about 5 p.m. and you would do a second dose early in the morning, usually about 5 hours prior to your procedure time. And then after that, and you can drink liquids up to that time. And then after that second dose, you just come in for your procedure in 4 or 5 hours. Now, the other thing that has just come out, literally, I think about 3-4 months ago, is a newer pill prep, which is very safe. And it's 12 pills at night, 12 pills in the morning, followed by a lot of water. So every kind of couple of years, there's like these new advances. And I will tell you, it's gotten much and much better. I've done the old version. I've actually done the new version. And I did the pill prep recently. And so these things are way better than they used to be with the gallon a jug the night of liquid the night before. So I think I will tell you, people always come in and they have this perception that it's going to be really bad. And the day of the procedure, they're like, oh, that wasn't really that bad. So it's really changed from what it used to be.
I like to joke with my patients that although alcohol is a clear liquid, it is not recommended the day before.
Yeah, white wine is not allowed as a clear liquid all day the day before.
Great, thank you. All right, next slide.
Yes. So this is actually a really hot topic in the literature. And I think that people and patients and women come in actually asking about this a lot. So it's nice to be able to talk about it. So what do we call this entity called SIBO? SIBO is known as small intestinal bacterial overgrowth. And it is the concept that you get a high amount of abnormal bacteria in the small intestine. And therefore your digestion is altered and you get a lot of bloating, cramping, and you can actually get subsequent diarrhea. And so it can lead to more significant consequences like malabsorption and things like that if it's really severe. But in most cases, the symptoms are really the most prominent. Now, people can have various types of risks that will kind of predispose them to getting this SIBO. And those include things like prior surgeries or causing sort of what we call blind limbs, where things get hung up in the bowel. And so it creates a little stasis and things kind of hang out and ferment bad bacteria. You can see that certain diseases of the small bowel, outpouchings of the small bowel, will also lead to like problems with these overgrowth of the bad bacteria. Actually, diabetes has been seen as well to cause SIBO. So that can be a very common underlying condition that people see. And then finally, I just want to talk a little bit about people who have like a slow gut, just a slow moving gut, a lot of constipation, et cetera. And those people have a very different subset of SIBO. And that's a more, a less common variant, but it's because things kind of hang out. And so they actually, their motility and their muscles move so slowly, they get a different type of overgrowth. It's a methane overgrowth, where the majority of SIBO is typically hydrogen overgrowth. So it's interesting, but it's, you know, it's broad in terms of its application in various scenarios. And a lot of people just get SIBO and there's no known cause. And so you have to think about it in anybody who's experiencing those symptoms. Typically, I do breath testing where patients really, they drink a liquid and then they blow into a tube every 20 to 30 minutes over a couple of hours. It's a simple test. There's actually available kits you could do at home. So during COVID, I had them mailed to people's homes and they would do it at home. The one that I like to use actually does both methane testing and hydrogen testing. So you get a very comprehensive look at it. However, I will tell you that the diagnostic testing isn't 100%. So if you do find that people are symptomatic, sometimes I'll just treat them. If they really classically fall into SIBO, I will say, hey, let's go ahead and treat you, because if your breath test is negative, I'm still worried that you might have it. So in those cases, I'll talk to people and say, hey, what do you think about this? And then treatments these days are a wide variety. There's antibiotics, and there's actually a very gut-specific antibiotic. That's sort of the gold standard. And it's very actually well tolerated because it doesn't get absorbed. So it just hangs out in the gut, and people are able to tolerate it really well. And it doesn't, interact with other types or cross-react with other types of antibiotics. It's sort of in a class of its own. And it's only taken for about a couple weeks, like 2 weeks, 10 to 14 days. And can be very simple. I usually follow it with a probiotic. Now, in methane overgrowth, there may be a little bit of different combinations that you could use as well. And then the diet is also a big part of SIBO. And, people who tend to get recurrent SIBO, I will be really aggressive about putting them on a diet. I will look for other kind of causes as well. Like sometimes you'll see it, you can find an underlying problem, and that's how you can address the SIBO. But the diets that I like to tell people about are two things: the specific carbohydrate diet and the FODMAP diet. And I'll talk a little bit actually about the FODMAP diet because it's used in other scenarios as well. But the specific carbohydrate diet is also a very strict diet in terms of reserving sugars. The big takeaway from the diets is that the more sugar and complex carbohydrates you have, the more you can promote overgrowth. So that's really the key. If you do the antibiotics, if you do the diet really kind of strictly during this time, and then you address any underlying problems, you can actually do really well post therapy and after a few weeks of making some of these modifications. And there are all kinds of things you can do for recurrence. Again, I said look for underlying conditions, give longer courses of antibiotics, cycle antibiotics. There's, the world of the literature is, still evolving. So that's something that is more of an art at this point, not as much of a science right now. And then I wanted to leave a couple of resources because I know people in the internet look for their own resources, and there's a lot of stuff out there. And I think the best, the two things that I usually give to my patients, one is a website called Gastro Girl, and it's actually the people who started the website partnered with the American College of Gastroenterology, and it's a fantastic website. It gives you really up-to-date information. Physicians are the ones kind of on the boards of this site that really monitor the information going out. The nutritionists involved have really good backgrounds in these types of diets. And so I encourage people to look at that website. The other book it's actually an old book, and I use it for my patients because I've seen it help in a lot of conditions, but it's called Breaking the Vicious Cycle. It's actually the woman who started the specific carbohydrate diet. Her name is Eileen West, and she actually wrote this book. And that's where the first talk of the specific carbohydrate diet came years ago, and I use it in my Crohn's patients as well. So it's a good. The book and her website is actually fantastic just to get information, and it's a great resource for people. I don't know, Eileen, have you seen people with this kind of question coming to your practice at all?
Yes. Oh, yes. I regularly. And what I hear, people worry about this becoming chronic or being a chronic condition and wondering how to treat it long term if it is chronic. And then the other thing that I hear a lot about is, hey, Dr. West, could this be yeast? Because there's a lot of information about there on the internet, and our functional medicine colleagues are talking a lot about yeast in the gut.
Yeah.
Can you address either of those, the chronicity of it or the yeast issue?
Yeah. So if it's chronic, what I found, and everybody's different, and there's so many anecdotal studies about this right now. It's so not well studied in that aspect. But I found that sometimes if you have an issue like really bad motility, for instance, Ehlers-Danlos patients or people who have really slow motility, you have to improve their motility in order to help the chronicity, because every time they have stasis in the gut, they get overgrowth. So I think with the chronic patients, you really want to make sure that there's not something else like gastroparesis, which we'll talk about later, constipation, if there's not diabetes, if there's something else that potentially you can alter. Now, if you can't alter something, then like I said, we can cycle antibiotics. We can, I give people like and you have to be careful about the antibiotic you use. I am very weary of giving people chronic antibiotics. I'm just not a big fan of that. So I really stress for them to be on the diet if they can, or try to find the exact triggers in their diets, and maybe start with the diet and the complete elimination, and then add things back to see maybe what they specifically are having problems with. So we do a lot of tweaking depending on the person about, how to address that kind of recurrence. And then there is a lot of talk of Candida, and I think our functional medicine colleagues are very adept at talking a little bit about that. In a more mainstream kind of medicine, we don't treat yeast. We think of it as a chronic colonizer, which doesn't necessarily give symptoms. And I think that our functional medicine colleagues treat it a little bit differently. So if people have questions about them, I usually refer them to them to kind of get a sense of, is this something that really they think they need to treat or not? We typically feel it, it's really a colonizer. And so we don't necessarily do it unless, unless there's a situation that would promote it in terms of the whole body.
Mm-hmm. Yeah, and it raises the question too, just about the colon cleanse. Colon cleansing has become very popular, but as I understand it, the data, the research behind the precise benefits of colon cleansing is pretty limited.
Yeah, actually, that's a great question, because I get that question a lot too. And I think there is very limited information on colon cleansing, and essentially, there is no real good data suggesting that it adds much benefit. And in fact, for instance, when you do a colonoscopy, you really basically do a colon cleanse. And we do see in some patients after a colonoscopy, when they do that cleanse, they kind of alter their microbiome. And so sometimes they end up in certain, anecdotal situations, I see them end up with kind of SIBO symptoms. So I'm very wary of, when people come in asking about that, I kind of explain to them, that all of this information, and kind of let them make their own decisions about it. But it's a great question.
Yeah, it seems like it might be better to think about it in terms of, a diet, like a structured dietary change.
Yeah, and I think what people are
short term. Yeah,
sure. Yeah, and I think people are really, what they're asking is, how do I get my colon to kind of move better? Because most people who want that typically never feel clean. So, you got to wonder if there's a more stable kind of chronic change that they can make with their diet, or even some, over-the-counter meds or things like that, to kind of help things move better, so they don't feel that kind of necessity to sort of have that cleansing sensation.
Yeah, to resolve the primary issue, which is usually constipation.
Correct. Yeah. Yeah.
Thank you.
Sure.
All right. Let's see.
So, this is another kind of big topic that I discuss a lot in my office with my patients, and I think I must get this question like once a day. I have to tell you, it's everyone asks, what is the best probiotic, and the corollary to that is, do I really have to take one? Well, my tagline, unfortunately, is like, there's not a best probiotic. So you can really, they're not FDA approved. There's no FDA approved probiotics right now. So you can market your own probiotic and put it on the shelf and say it's the best probiotic. So really, you don't have to, you're not going to be able to say this one is the best compared to every single other probiotic on the market. The other question that is sort of similar to that is, oh, I got the good one, the one that's like in the refrigerator, which is, I'm sure you hear that too. But
I do all the time.
Yeah, it's sort of this common question, and I'm not sure where it comes from, but I think maybe people hear that, well, it's refrigerated, so that means that the bacterial species are like alive and they're working. And the reason that some are refrigerated and some are not is because certain bacteria are shelf stable at room temperature and others are not. So the ones that are actually available over the counter in the non-refrigerated regular aisles, those typically are the bacteria like bifidus bacteria, certain bacteria that are all shelf stable, like Saccharomyces, lactobacillus, like some of those are all all normally stable at room temperature. If you get other combinations of bacteria, they need to be at a certain temperature, and that's why those are refrigerated. So just remember, it doesn't mean that one is necessarily better than the other. Now, the AGA, which is sort of our general governing board of GI, has recently actually done analysis on all the data. The data is not great. You know, there's not great big studies because there's not pharma involved, and it's not just this robust information that we have. But they did go through all the studies, and they set guidelines as to what was helpful. So what they found was in 2 situations that the probiotic has actually been helpful. One is to prevent something called C. diff when you're on antibiotics, and antibiotics can promote and cause a gut infection called C. difficile, and it can be a really significant infection. And Saccharomyces, or the brand name is Florastor, is a probiotic in which there is good data that suggests that if you're on antibiotics, you follow this by a course of the probiotic, and you actually have some reliable way to prevent this C. diff. So it's actually really important in patients who've had C. diff before, particularly, or you're on a really long course of antibiotics. The other condition is something called pouchitis. It's a very specific subset of patients with this condition called inflammatory bowel disease. So if you have it, you know about it, and it's something you should talk to your doctor about. And that's always been the case, that specific probiotic like VSL3 has been shown to be beneficial. The other data has yet to really come to light, suggesting it in things like IBS or symptoms and things like that. So that's still kind of out for study, and nothing's been said specifically about them. I will tell you my personal anecdotal experience is that you should try it if you have symptoms that are diarrhea, bloating, which are the most commonly that seem to help the most common. And it's worth a try. It's not going to be of harm unless you are immunocompromised. And that's one situation where you have to just be careful and talk to your doctor. So if you are on an immunosuppressant medicine, if you have an immunocompromised state for some reason, for instance, chemotherapy, I always ask them to talk to their oncologist. You should always be careful. That's the one situation where you don't want to cause a problem. And there's actually really good data that this pediatrics, it's helpful as well. So I think that it's, there's a lot of use in the probiotics, and there's a lot of information still coming out. I will tell you that probiotics and SIBO is still a little bit, up in the air. I don't specifically think, everybody's so different, first of all, with their SIBO. So it's very hard to tell, should you take a specific probiotic or not? I think that no one really knows the right answer to that at this point. So it's really hard to say in that scenario. I think you should basically understand that it's for your symptoms. So if you feel worse on the probiotic, you should stop it, because there's no real indication. Like, there is not a reason that is clinically is developed yet that says you have to take this to treat X, Y, or Z beyond what I've just told you. So I think that if you are not feeling good on the probiotics, you stop it. That's really the bottom line. And, it's kind of interesting. There are many strains of probiotic, and I will, there's not a specific one that's really great for women. I think somebody's asking if there are specific strains that are better for women, and that's just not really validated at this point. I think there is a lot of marketing done with the probiotic companies, so it's hard to differentiate all of this information. But there is not one in particular. I will tell you my own practice, and like I said, this is just what I do. And again, you have to look at the literature, because it's so all over the map that we do whatever we feel like may help people, that we've seen help people. So there's a couple strains, like the bifidus bacteria strain, a combination of that with the lactobacillus, Saccharomyces, that I use in certain situations, and I think that have helped people. And I think if you actually switch probiotics, it's sometimes helpful to see, if I didn't respond to one, well, maybe I will respond to a different one. And if you're going to switch, you should look at the compound the probiotic has and switch to something different, and see if that actually helps you, because that's the one way that you can actually, I think, do something that would, at least scientifically, make sense.
Mm-hmm. Dr. Khapra, are there, when you talk about prevention for C. diff, is there, and you mentioned longer courses of antibiotics, are there any specific antibiotics in particular that you worry about? And by long, are you talking a week or more of treatment, or 10, like, you know, patients get treated all the time for things, 3 days for a urinary tract infection, or some penicillin for strep throat, or, I mean, should those people be thinking about probiotics if it's just a simple antibiotic, or are you thinking more about the heavier hitters that last, 10, 14 days of treatment?
Yeah. So I think in particular, if you are, I think the short courses you don't have to worry about, because those shouldn't really do very much in the short term. I think the people who I specifically say longer courses, I mean, people who are on, for instance, recurrent courses, like they get a lot of recurrent sinus infections. So they almost seem like they're chronically on antibiotics in the winter, or, even UTIs if they constantly get them, or if you have a really sensitive gut and every time you take the antibiotic, you feel like something is just not right. So I think you don't have to, it doesn't mean that everybody has to really take it, immediately when they're on a antibiotic. Now, there is a specific antibiotic, for instance, clindamycin, that dentists give, for instance, that has high rates of C. diff. So I think in that particular instance, it may be worth it because there is a high association with that antibiotic with C. diff. And I think it's good to ask your doctor if they think that this is going to give them a risk. And, it's a simple solution. I usually tell people take 2 pills of Fluorostor every day for a couple weeks just to kind of even out their gut after that.
Mm-hmm. And is that by prescription or over the counter?
Nope. It's over the counter. It's shelf stable. It's even actually what's really interesting. It's a capsule. And you can actually even open up that capsule because there are time release beads in there. And so like I actually used to give it to my kids when they didn't want to swallow a pill. I would open up the capsule and just put it in food and let them take it. So it's a little trick that I used to do with my children because they're kind of big capsule. If you see them, they're actually fairly big capsules.
And there is a role for just, yogurt or, the lactobacillus, and, I know people that some of the yogurt companies market that, they've got the best probiotic and that, they'll set your gut straight in 2 weeks. And
so it's actually interesting. I think you're totally right. I think there's a big role for diet. And I didn't include, that's one thing I should have included actually on this slide, because you're totally right. Fermented foods, things that like yogurts that have live culture. So you want to make sure it has a live culture. The interesting thing is they did a study, particularly with a probiotic, I think it was Align, which had some, benefits in IBS and things like that in small studies. And the actual amount of yogurt that you needed to get the same amount that you get in, for instance, Align was I think 2 to 4 a day or something like at a high rate. So I think you have to be mindful that also if you're doing that and you're using a dairy source as your main kind of probiotic, what ends up happening is if you get too much dairy, a lot of people who use probiotics may be very sensitive in terms of their gut, and they may be lactose intolerant. So then you may end up, creating a little bit more issues with lactose intolerance if you're eating a ton of yogurt. So you just have to balance all of your own particular issues. And if it really is hard for you to get the foods in, whether it's kefir or sauerkraut or whatever fermented food you want because it doesn't sit well with your gut for whatever reason, then you should think about just doing the supplements.
Mm-hmm. Great. Thank you. All right, let's see. What's our next question?
So chronic constipation, we touched a little bit about this when we talked about SIBO, but, chronic constipation has really been a topic people come in with a lot of issues with. And I think it is such a complex topic, and it sounds so silly for me to say that, but it can be caused by so many different things. It can be caused by women's hormones. It can be caused by just having a really slow gut, or because that's just the way it's been in your family, or because you have an underlying problem with your gut, like Ehlers-Danlos or some kind of collagen vascular disease or something like that. The other reason women particularly have it is because of pelvic floor problems. So after childbirth, the pelvic floor may not be as strong. And so sometimes then the outlet or the way that you actually evacuate is difficult. And then finally, IBS, super common in women. IBS is irritable bowel syndrome, which we'll talk about in detail in a minute, but there's a predominant constipation phenomenon in that too, in a subset of IBS. So as you can see, it's sort of all over the map in terms of reasons to get chronic constipation. And I will tell you, there's so much more now than there was even when I started practicing 15 years ago. I think there has just been an explosion in terms of availability and medications and options and things. I think the best thing to do is always just start easy, like start with the most natural stuff. So I tell people, I'm actually very particular about going through people's diets, because you ask somebody what's your diet yesterday, and you can tell right away, are they getting enough fiber or not? Because that's the number one thing that people don't necessarily do. So the best fiber kind of amount to get during the day is about 25 to 35 grams per day. And if they actually did a study years ago, I remember this was in, I think it was kind of all over the news, and they looked at what the average kind of American had, how much fiber they had in their diet, and they found it was only 10 grams. So even if you think you're getting a lot, you probably aren't getting as much as you should. And so I always tell people it's easy calculation. You can Google a quick sheet and figure out how much fiber, certain fruits have much more. Raspberries have a ton of fiber. All brand cereal has brand in general has a ton of fiber. So you can just easily find that information and do a quick calculation yourself. Exercise is huge. I've had people who stopped exercising for a month, came in with worsening constipation, and we looked for everything, and it turned out that they had company in town and they stopped exercising for a month. And so you will be so surprised how well your gut moves. Your gut, your colon is a muscle. So if you are exercising your other muscles, you'll be exercising your colon. So think about that as a really big way to move forward with kind of holistic options for constipation. And then, magnesium supplements are a little bit of a trick that we use. I'm a big fan, actually. You have to be careful, though. You can't use too much. You have to run that by your doctor. But at small doses, magnesium is great for constipation. It's great for leg cramps. It's great for headaches. It helps with sleep. So you take a low dose at night before you go to bed. And I've had some people that just need, fiber and a little magnesium, and they feel great. And so it's something to try. And again, like I said, if you get too much magnesium, you have to be careful that you talk to your doctor, because you don't want a cardiac side effect from and that's really high doses. So you just want to be careful with whatever you decide to do, even if it's an over-the-counter agent like magnesium. And then, over the counter, there's tons of laxatives. Everybody comes in with a different laxative regimen, I feel like, these days. And I will tell you, the safest over-the-counter laxative is something called Miralax, which is termed an osmotic laxative. And what that means is that water is actually brought into your colon so that it helps you have a bowel movement. There is no extra stimulation. It doesn't typically cause cramping in most people. It's a very more natural way to have a bowel movement. And because it's not a stimulant, you can actually use it forever without getting this concept of a lazy colon or requiring higher amounts. It's the kind of laxative of choice in pediatrics and toddlers for bowel holding issues. It can be taken safely. You should talk to your doctor if you do think you need it long term, just so you're taking it properly. But it's something that is in my book like fairly safe for the majority of people. Now, I would avoid things that are like senna based, because even natural things like senna teas and things, they're stimulants. So even though they're natural, they do stimulate the gut. And so you may get more and more requirement over time and start to get a little bit of a lazier colon. And you want to avoid that on a long-term kind of management basis. And then the other thing is prescription. So there is now, I can think of about 5 or 6 different medications that are prescribed for chronic constipation, and they're in 2 different classes. One is where they bind to the channels of the colon and improve the motility, and the other is hormonally driven. And so these are great medicines. They're extremely safe. You should talk to your doctor about them if you feel like you've exhausted those over-the-counter options. But something to know that there is help available, so you don't have to suffer in silence. For people who have the pelvic floor issue, and as you know, as women get older, it's sort of a natural thing for the pelvic floor for many reasons, for if you've had GYN surgeries, if you've had children, even if you've had chronic constipation that can cause pelvic floor problems. So I send people for physical therapy, pelvic floor physical therapy in particular, for biofeedback, where you kind of retrain your like brain to like sense a bowel movement and evacuate properly. There's actually specific tests for that too. And these tests that I mentioned here, and you can see it on the slide, you know, there's a ton of testing. If you feel like you try things that doesn't help, maybe you need to talk to your doctor to send you to a gastroenterologist to really hone down what the actual problem might be and see if we can target your therapy a little bit better. So I think those are, you know, those are things that can help get you started. I think there was a question that said, is there a specific fiber supplement you recommend? So I think there are two specific ones that I recommend. The one that's sort of my go-to these days is Benefiber, because it tends to cause a lot less gas than like psyllium husk or Metamucil. But though psyllium as well has its own benefits, but it does tend to be a little bit more gas promoting. The other thing about Benefiber, which is super easy, is you can just put it in your coffee, stir it, and you don't even taste it. So it's very easy to use. Gone are the days of the big shakes, you know, the big orange shakes people used to say their grandmothers had with the Metamucil shakes and things. Like that's sort of the older version of probiotics. I think the newer versions are really these ones that can be very easily taken. And I think if you can do it simply, you're going to be doing it a little bit easier on a daily basis. Dr. West, any other things that come up in your practice or things that you can think of that are?
I think people have a tough time really estimating how much fiber they all think that they're very well hydrated, and they all think that they get enough fiber. And so sometimes when you actually sit down and look at the numbers, it's surprising for them too. It's educational to realize that, you know, as hard as we try, none of us is ever going to be perfect with it all. We have to keep an eye on what enough fiber really means.
You're totally right. And if you are taking your good amount of fiber, you always have to make sure you're right, that you're getting a good amount of water. So an easy way to say that is, if you want to be really aggressive, is just take your water and your body weight, you know, like you take as much, you know, pound per pound, you know, ounce per pound of water and body weight, or kind of find a way to like get a calculation of what you want to reach.
Is it per kilogram or per, I have to think about those, or half of your weight in pounds or weight in kilograms, right?
So the way I look at it is I usually try, it's half of your weight in pounds.
Okay.
So typically that's the number that we, you know, I go by just as a gestalt, or you know, people don't want to like, if they want a minimum amount, I say take 6 to 8 glasses a day, you know, like hit a minimum so that, you know, in real terms, like what that means, like, so, you know, if you're not someone who measures out your water and things like that, you know, keep it simple.
And I also like to remind people that for every cup of coffee, you've got to have 2 cups of water to make up for it. So, and that's in addition to what you're already doing, just because of that diuretic effect of the caffeine.
Correct. Yeah.
Great.
So, all right. Should we move to the next slide? Because this is actually, gastroparesis is a topic that sort of tag teams a little bit with constipation. So it's timely because this month is Gastroparesis Awareness Month. So it's nice to talk about it in this time period. And actually the word gastroparesis is literally translated as partial paralysis of the stomach. That's like the definition in literal translation. But what it means is that the stomach moves slow, or there's a delay in where the contents empty out of the stomach. Now, people sometimes confuse this with what's coming out of the colon, like stool production, and this is totally different. So what this means is that typically when you eat a food or whatever you're taking in, it takes your stomach about 90 minutes to empty half of that content of your stomach into your small intestine. And so this is a normal, what we call half time of emptying. But when you get a delay, some people can have up to like 500-600 minutes where the food sits there and doesn't empty out of the stomach. And we can see this in various conditions. So it's the most common you'll see it is in diabetes. So people who have diabetes with sugars that are actually over 200 consistently, or that are very fluctuating in those high ranges, will get very symptomatic from it. So it's the first thing we think of when a poorly controlled diabetic comes in. I will see it in patients who have autoimmune disease, for instance, like certain types of like collagen vascular diseases and things like that. We do see it in post-viral infection. So if you get an acute infection, whether it's the flu or something just not even GI related, you can develop this post-viral gastroparesis. And unfortunately, while we go through the whole list of all these diseases, often we just don't know what causes it. And so there is a big subset that's unknown. So I think you have to think of it if you're thinking of the correct symptoms. And what symptoms would people have? Well, people typically they feel full very fast. So when they eat, they can't eat a normal sized meal because they feel like, they've eaten for the full day that day, or they get very nauseous easily, or they actually start vomiting undigested food. That's sort of the classic teaching, but it doesn't always happen that severe. And in the really severe cases, people will kind of be persistently vomiting and not even be able to maintain their weight. But that's a little bit of a smaller subset. I think more often in the general population, it'll really be this sense of fullness, nausea. I can't eat a big meal. I'm very bloated. Bloating is one of those key things that people say, or like, this is a very common thing where I can't close my bra strap because I feel so tight in my chest that I can't even feel comfortable. So those are sort of these hallmark things that people come in and complain of. And it's interesting because it can make you feel really bad, but it's actually not that dangerous. So like, it's a functional problem. It means the stomach is just slow, but it doesn't cause anything else that's severe. It's not going to cause cancer. Like, there's no other bad sequelae of it, except it can make you feel so bad. So diet, as you can tell from my other slides, I'm very aggressive about talking about diet in my practice and to my patients. And I think small, frequent meals are the key. First thing is small, frequent meals. So if you eat small amounts throughout the day and not allow your stomach to empty, think of a motor, and it works in a chronic sort of fashion instead of like stop, go, it'll work better. The other thing is what you put in your mouth is actually really key. So you can eat things that are kind of not what we call low in residue, but not grainy, not stringy. They're kind of mushy. Like, you think of baby food, right? It's all kind of mushy. It all goes down easy. Liquids don't take any work for your stomach to empty. So if you stayed on a liquid diet all the time, you'd probably feel great. And then the stepwise up from that is like, mushier foods will make you feel good. So try to avoid things that are like stringy. Take your peels off your fruits. Try to avoid nuts. Try to avoid lots of grainy breads. Asparagus, super stringy. So I tell people, don't avoid that, but throw it on a smoothie and strain it a little bit, and you'll get a lot of the same nutrients that you can. So I think diet is totally key. There are good nutritionists out there. GastroGirl has a list of nutritionists that can really help with this, because you got to go to the right nutritionist as well, because it's a very specific GI condition. And if someone tells you to eat a lot of fiber and you end up eating raw salads and all this raw vegetables, you may feel worse. So diet's very important. I think medications are unfortunately not great in this area. There's a lot of study right now in medications, and I'm not even going into this because it's such a tough area. But I mean, there are things, talk to your gastroenterologist, that we've tried that are even off-label use that can be helpful, and we can definitely get people better. But it takes a lot of work on people's part to really do the heavy lifting with some of the diet, things that I mentioned in this slide. I'm not sure, Dr. West, we see it from a gastroenterology standpoint. I'm not sure if people bring this to your attention, or have you seen patients a lot in your practice?
Yeah, it's typically when the diabetes is a little bit more advanced. So I don't see it as often in the clinical setting as I might see it in a hospitalized patient. So, but it's good to be able to have some advice for folks, and I remember many patients taking care of on the inpatient side, trying to figure out how to fix the gastroparesis and terrible constipation that would come up while they're hospitalized, then because fiber and fluids just isn't always the right answer in that setting. You have to do something to help to get things jump started. But you know, prevention. It's the, you know, an ounce of prevention is worth a pound of cure.
Yeah, and I think it's good to know about, because I think that what happens is, unfortunately, at least what I've seen, is that it becomes something that people think of very late, even gastroenterologists. And so people may be sick for a while. And so I think it's good to have on your radar. It comes with constipation because sometimes the entire gut moves slow. So you fix people's constipation, but they still feel bad. And then you think, okay, why are you still feeling bad? You're going to the bathroom every day. It may be that the stomach's just not moving. So I think it is one of those things that's nice to have on your radar, because, you know, a lot of these GI symptoms tend to overlap. And so it's hard to really tease out what is, you know, what is going on.
Absolutely. Great. All right.
So IBS, I'm sure you see a lot of IBS. I have to tell you that it's,
Yes.
yeah, it's a mainstay of my practice as well. And I think the nice thing is that these days we have a lot to treat it. I remember I had a patient who came in and said to me, my gynecologist sent me, I know I have IBS and I know there's nothing you can do for me. That was literally the first sentence out of her mouth. And I said, well, give me a chance, because I just met you. And, you know, and so we went and we got her feeling better. And I think she came back, I remember, at one of her visits, and she said, you know, I have to apologize. I really didn't mean that. And I said, that's okay. I was like, unfortunately, I think that's the word on the street, is that, you know, there's nothing I can do about it. I'm just supposed to eat better, and that's going to be it. But, you know, it's a functional problem. It means your gut is super sensitive. And technically, the definition is people who have 3 to 6 months of abdominal discomfort associated with bowel changes or improved with bowel evacuation. And it can either be predominantly diarrhea, so you can have IBS with diarrhea, or you can have IBS with constipation, or you can have what we call mixed IBS. Those are very difficult to treat because it's sort of a moving target a little bit. But as I mentioned, there are so many medicines now. There are things, I start with supplements in a lot of my patients. Peppermint oil supplements are kind of one of the newest things that we see really big benefits in. There's things that relax the gut that are very safe. The medicine for SIBO that I mentioned, that antibiotic called Xifaxan, has now been approved for IBS with diarrhea. So, and that's a fantastic option because it's a limited course that is just taken for 2 weeks. And then there's meds that are targeted specifically, for instance, IBS with constipation, or other ones that are IBS with diarrhea. So the list is so large right now that I think that, you know, you can, if you really have someone who will sit down and listen to you, then you can kind of work through what would be a good option, and, you know, what works for you, because it's not one size fits all. It's definitely everybody is different. So you kind of have to figure out what's a good fit for you. The other thing that I think is fantastic, it's been like one of my, I think one of the biggest advances in IBS is diet. And for many years, there was nothing. People would just say, oh, eat a lot of fiber, or, you know, just improve your diet, clean it up. And in 2011, there was a Australian gastroenterologist and nutritionist who, from the Monash University, who came up with this diet called the FODMAP diet. And over the last 10 years, it has really become the validated diet for IBS with diarrhea. And it basically is a 6-week elimination diet in which afterwards you add, in 2-week increments, you add things back in, and basically allow you to figure out what your main trigger is. And the diet, in a nutshell, and this is kind of sort of simplifying it a lot, is avoiding things like most dairies, gluten, and fructose. And fructose is actually something that's new, because a lot of people know about gluten avoidance or dairy avoidance, but fructose is actually in a lot of naturally occurring fruits and vegetables. So like apples, very high amounts of fructose. Honey has a high amount of fructose. So there's fantastic resources on the FODMAP diet. There's a book the Monash University puts out. There's a recipe. They have an app. I mean, the resources are phenomenal. So if you haven't tried it and you have IBS with diarrhea, it's something that a lot of people actually come in asking me about. So I think it's very well known in terms of do it. There's actually some companies now that are giving meal plans and actually will serve you, like, you know, kind of some similar to these other kind of home meal deliveries will do, like the FODMAP diet. So something to look out for if you haven't heard of it, you know, lately, if you haven't looked at it lately, because a lot of new stuff has come out just even in the last 6 months to a year. And then finally, something that I actually have resources I've been looking for, finally found people that would help me with this. But there's a lot of people who suffer from IBS and either develop anxiety because of their IBS, or they have a component of anxiety that is contributing to their IBS, and it's a cycle. So if you can get either some sort of therapy for the anxiety trigger, or there's some specific psychologists who specialize in the gut, and they do hypnosis and cognitive behavioral therapy, and it's fantastic, and it can be really life altering for some people. So I think, again, there's some local people that I send to here. There's some, now telehealth has opened up the market for everything. So I think it's something to think about if you want to go a more holistic route, because it can really be an added benefit.
Wonderful. You know what I would love is a list of your favorite resources that you make available to your patients, like the guideline, the name of the diet, or the name of the company that does the
sure.
diet. That would be so helpful. I'll just put them all on a single page here in the clinic, and then I'll have it to share with patients. That's great.
Yeah, there's so many resources. I think the problem is there's too much, and people don't know what.
Yeah. Or maybe pick your top three favorites. I know, challenging. Yeah. There's a question, would chronic diarrhea be connected to IBS, or or SIBO? And I guess the answer is probably either, right?
Yeah, so that's a great question, because when the studies were done with that medicine Xifaxan that's used for SIBO, it was first used in SIBO, and then it was studied in IBS, and it was found to be like it's FDA approved now for IBS. And so I think the theory is, and this is not, the ongoing, what people say is that there's probably a subset of IBS patients that have chronic SIBO. And so they respond to Xifaxan. And so I think you're right. It's could be both. And it's really hard to know unless, you did like a really controlled study for it. But I think it's both. There's an overlap.
Mm-hmm.
It's a great question.
Mm-hmm. All right, we're down to our last slide, the last question. Let's take a look at this.
Yeah, and I'm sorry for the text-heavy question. There was a lot to say, because I think that in my practice over time, I think that you see more and more people around the time of menopause come in with IBS symptoms. And it actually is one of those things that's very hard to delineate whether this is just the hormonal changes or if it's something else. So you typically want to make sure it's nothing else. And then you start asking questions about, what's going on with your cycle and where are you in that time of life? And then you kind of put two and two together, but it can really exacerbate any underlying even tendencies to GI problems. So you can see, a lot of gas, bloating, discomfort, like all the IBS type symptoms. And so you'll see that kind of crop up. And some people actually will have it around menstrual cycles. So you'll see that people say, oh, I get these kinds of symptoms a couple days before my cycle, and then they go away. So that's sort of the mild version of that, but you'll see it really prominently even around menopause. And, there's the estrogen progesterone levels in perimenopause and menopause, they change. And so it affects how fast food moves through the GI tract, and actually ultimately can lead to constipation over time. But when people are first in perimenopause, because you see these fluctuations and things kind of are all over the map before they change completely for menopause, you'll see that people get bloating because of these fluctuations. They retain more water. And so in that sense, they tend to have bloating as sort of the main component. And then after menopause, or as menopause sets in, you will start getting some constipation. And then you can actually get bloating related to the constipation. So it can be, it can be a frustrating time for people, because you go through all of these other known hormonal things like hot flashes, et cetera, but you don't expect your gut to be miserable too. And there are if you can manage your gut symptoms, which you can do with some of these IBS medicines and other kind of tricks to the trade about constipation and things like that, at least it can alleviate some of those hormonal surges. And, we think about hormones in pregnancy, for instance, where you get a surge of progesterone that relaxes the lower esophageal sphincter and allows for reflux. So everyone talks about reflux in pregnancy, but the menopause and postmenopausal hormonal changes are less talked about, I think. And so I think people are a little surprised, or they're a little, they get these new symptoms and they get a little bit confused as to like now what is going on now. So I think it's good to be aware, because you can actually do a lot of, you know, things to kind of ease that transition from a GI standpoint.
Great to know. Thank you so much. It just goes to show once again that how hormones run our lives.
Yeah, it's actually very, I find the whole hormone, the brain gut connection, I think is very fascinating. And I use a lot of, you know, anti-anxiety meds for IBS and people who are very sensitive. And it's just, you just need a little whiff and people feel great. So hormones and various, not just the, you know, gynecological hormones, but even the brain gut axis is very prominent.
All right. Well, wonderful. This has been fantastic. Thank you so much for being here and for going through these pictures and slides with us and covering a lot of the top questions. I think we really, I'll be eager to hear if, you know, additional questions arise. We can bring you on for a part 2.
No, I think it's really helpful for people to hear this, because I think it's hard at a doctor's visit to get like a lot of information. You know, you have a limited time and there's a lot of things you want to talk about. So it's sometimes nice just to kind of like give people a little bit of an update.
Yeah. And I think it's overwhelming sometimes, the volume of information that's out there. And, you know, it just can be hard to know which source to trust. And, you know, really you'll hear directly conflicting advice from 2 different places. And how do you know what's really the right way to go? So hopefully we're able to shed some light on some of those answers for people today. So
yeah, and I'm happy to come back if there's anything that's left that comes up, because there's a lot to talk about.
Yeah, for sure. Well, good. Well, we're a little bit over time, so I think we'll go ahead and let people go and get on with their afternoons. But so grateful again to you, that Dr. Asma Khapra from Gastro Health here in Northern Virginia. And I'm Dr. Eileen West, general internist here in Fairfax, Virginia. And I look forward to having a chance to talk with you again.
Yes, we'll see you soon. And I will get you that resource, I promise.
Fantastic. All right. Thank you. Take care now.
Take care.